the sessions. And then we can send out the recording of the video to anyone that might have missed, or if you want to revisit the information. So here we go. Okay, so measuring social determinants of health information. The presenters today, my name is Craig Christensen. I'm co-founder of H4 Technology. We are a data management as a service company. We integrate and analyze data. And co-presenting with me is David Whitesock. David, you want to introduce yourself?
Sure. Thank you, Craig. Yeah, I'm the founder and CEO of a company called Commonly Well, and we take technologies like what you'll see today with the Recovery Capital Index and social determinants and bring them out to organizations in the behavioral health, public health, and addiction treatment environment.
Great. Like I said, this webinar will demonstrate how a mobile social determinants of health solution can help improve outcomes by identifying and continuously monitoring changing SDOH needs of consumers. A little bit about us. So we've been in, H4 Technologies has been around since 2012. We've been in the data management and infrastructure and analytics industry. We got 4 or 5 different modules now that we've grown out of in our marketing. We have social determinants of health. We have a claims data management analytics for denials, denial management, reconciliation, those type of things. We've taken data out for financial analytics. We created a population health module, and then through our behavioral health sectors, we have encounter-based systems that rolled up to episodes of care. So, so you can see multiple encounters rolling up for an individual over multiple services to an episode of care. The sectors we are involved in is state behavioral health agencies, behavioral health providers, state hospital associations for data aggregation, individual hospitals, so as well as ACOs and strategic health information technology partners. When we're looking at what we have from a social determinants of health perspective, a bigger conversation is happening on healthcare data aggregation and a consolidated SDOH data set. There's teams, and I think CMS is putting together core items that make up that data set. When we were looking at what we had built for the state behavioral health departments as well as behavioral health providers, well, we have had 95% of this data already in existence for multiple years. And so my partner Chris Henkenius is working with groups to identify and finalize some of those SDOH data field level elements, as well as work to I guess move that session forward for what becomes the SDOH data set that we can all agree on and share data on. So when we're looking at the social determinants of health module and solution we have, there's kind of starts with a couple different components when you're looking at SDOH. So first there's the data aspect. So a lot of times the core fundamental pieces you're looking at is patient demographic information, information out of an EMR. Additionally, you can combine that with claims data or other publicly available data. Then there's a variety of assessments. So prepares one, RCI, PHQ-9s, DLA-20s. Once you have all the data in, then you can help with either the prediction models, so you can risk stratify those patients to look for likelihood of readmissions and ER visits. Additionally, then we can look at the patient identification. So this is where the SDOH needs are identified, whether that's housing, food insecurity, transportation. And if you're continuously monitoring those type of things, Then you can identify the changes and whether a patient or consumer needs different resources. Alerts and notifications can be available to you for that, and that just facilitates some patient engagement. From the community perspective, there's a lot of I would say buzz around community resources and networks of providers and networks of nonprofits to help facilitate that. 2-on-1 centers are traditionally a statewide element, as well as there's groups like Aunt Bertha, Unite Us out there that are connecting and integrating with various groups to prepare that resource directory. What we are seeing though from our side and what we're able to help with is the actual identification of who should be involved in that referral network up front, as opposed to a reactive model where they come through the ER or ED. So additionally, a latest, innovation is that we're developing this SDOH API to reach out to those referral networks and have the ability to share a standardized data set across the referral networks that maybe a health systems is partnering with on that. One thing that, we have a variety of assessments, and out of our work with the behavioral health departments is, we have over 1.5 million lives on our platform and using the encounter-based system where we're tracking health statuses, substance abuse, diagnosis, claims, and whatnot. Additionally, we have built assessments where we can track individual data points, and this is something we've had for years. What this was kind of a report and then analyze type of model, and it wasn't ongoing or as real time as it maybe could have been. And so what we have done now in partnership with David's group is enabled and further enabled this SDOH platform to be a text and email assessment of the RCI. And so now we took the RCI. David will explain the methodology behind that, but we've brought it forward from a technology perspective to enable text and email communication with consumers, gather those scores real time, and then report and analyze the data and identify SDOH needs and trends. And so that capability has been, I think we're coming up on our 1-year anniversary now of developing that and launching it. And so without further ado, I'd like to introduce David Weissock and with Commonly Well and the RCI assessment. David.
Thanks, Craig. Yeah, I'll give a little bit of a brief background on the Recovery Capital Index. In 2012 and 2013, I was working for a nonprofit that provided peer coaching for drug and alcohol addiction in the upper Midwest. And in the course of doing that work, we needed a model to measure outcomes. And there just wasn't anything sufficient that existed at that level for a small organization like us. But we were an organization that worked to try to figure out some things kind of on our own, and we moved down this road of trying to understand recovery capital. We knew in the work that we did that the binary of sobriety just wasn't sufficient. That was one data point, but it was fraught with all kinds of peril in stigma and in motivation for change and all of those various things. And so the concept of recovery capital, which is what was in our world, and along with social capital, which is a much more broader construct, ties very nicely to the conversation that we have today around social determinants. And so the framework that we had developed was this framework of these these three domains, but you could look at this, take it out of the context of drug and alcohol addiction, and place this really into any quality of life framework for any of us who happen to be talking here today. So that's the framework of the Recovery Capital Index, and really trying to get at all of the things that help or hinder the growth of somebody's health and well-being. Go to the next slide, Craig. And so in that process of just figuring out the construct and knowing that we wanted to measure something beyond sobriety or abstinence, we had to create a questionnaire. We knew it would be a subjective data kind of process. And we landed on a survey instrument of 68 questions. It started much longer than that, but we were able to get it down to 68 questions. Those are obviously qualitative in their construct of the statement and the responses, but we needed to quantify it as well. So we attached and created a formula for a 100-point scale, so we could have both that qualitative and quantitative aspect to that survey instrument, which for most of you is probably something you deal with in other assessments on a day-to-day basis. And then, of course, over time, over many years, actually figuring out that the most viable and meaningful and reliable frequency to get that information and be able to use it in a really meaningful way was around 30-day intervals. And so we were able to set that up and then automate that process over time. Next one, Craig. And in the course of developing the instrument over time, obviously, when you create something sort of out of whole cloth or bring other valid items from the world, we had to go through that process ourselves. And so when we talk about the Recovery Capital Index as a stand-up assessment, we put it through the scrutiny of determining its reliability, and partner with statisticians at Sanford Research in Sioux Falls, South Dakota, to take it through that rigor. And we were able to validate the instrument so that it has a reliability against various elements that we might be checking along a person's path of well-being. Next one, Craig. We published that article in May of 2018 you can go back one more, Craig, in the, sorry, you're jumping, there we go. We published that article in May of 2018, and I'll just kind of skip ahead here just a moment and say that because of that publication within the nonprofit that I was working at, we had been using the instrument for close to 5 or 6 years at this point. But now that we had kind of put it out there in the open like that, and we started getting inquiries about could we take this further and beyond that organization, and ultimately that's sort of how the connection became between H4 Technology and the work that I now do outside of that nonprofit, and creating a separate entity to bring that instrument to bear. One thing about an instrument like this, and you'll see this, when we look at the demo here in a moment and look at some of the data, is it's not just individual information. It is, of course, the survey assessment gives you that individual personalized data set that you can track change at that particular level and personalize care. But you can also, move up, in kind of a hierarchy of understanding the aggregate information at the organization level to really see, where are some of the confluences of what we do and the interventions that we provide and the care that we're doing at an organization level, and are there gaps in what we do relative to the social determinants that are out there for the population that we are serving. And of course, if you're tracking that against the population over time, now you've got this sense of long-term outcomes that you're tracking against. But you can also go one level higher, depending upon where your organization might be in terms of its engagement at a community level, whether it be for policy or design constructs for well-being and quality of life initiatives and collaborations. That community sense now gives you a voice of all of these individuals who then can be mapped in terms of their health and well-being at a community level, and start to see, okay, how can we as a community or as those that can affect change can work with various organizations collaboratively to then allocate resources in the right way to build health up for not just the individuals that we serve, but for all individuals that might be in the community that we serve. Next one, Craig. And you'll get a sense of that as we go through here and we look at one particular data set out of Palm Beach County. When we developed the Recovery Capital Index in particular, it was focused primarily on addiction and addiction recovery. But a lot of the questions, about half of the questions, actually come from general quality of life instruments. Some of the items and the instruments that Craig had shown on a previous slide, those are items that have existed in the public domain for a long time. There's no need to reinvent that wheel. So when we look to applications of this particular assessment, it can be molded into various different places, like problem-solving courts within social service organizations that do care coordination across many different conditions, at the big community levels, but also within healthcare generally as well. And because the questions are and the statements are really rooted directly into that general well-being construct, it's pretty easy to tailor them away from addiction recovery in particular. Next one, Craig. And so, as you all know, we're in the midst of 2020, and it's been a challenging year. And seeing some of you turn your cameras on, we're at home, we're working at home. It's been a challenge with coronavirus and how it's now disrupted, just life generally, the social fabric around. The country is being challenged in a lot of ways because of coronavirus. Technology is playing a bigger part in our lives, and how do we, live with these technologies that are always on, like we're doing here today with a Zoom call. And of course, we've got the election and various elements around, political strife and different aspects that way. So there's a lot going on, and that has impacted individuals' emotional well-being, mental well-being, and physical well-being. And so can we see that? Can we see some of this happening to us in the data? And as the next slide will show, we've been using the Recovery Capital Index in one particular area since last October. So in Palm Beach County, where we have a partnership with the county and a managing entity of a handful of treatment providers and other service providers, we've been tracking Recovery Capital since last October, November, and looking at the data from December, which was the most reliable, to this current October. You can see, just observationally, you can see that there is really a tightening of what we call recovery capital, of those determinants. And if I threw a trend line in here, you would see that trend line starting to go down. I can't answer specific questions of, is this as a result of COVID? But you can see that right around February, March, April, there's a significant spike. When we look at the data more closely, we can see some reasons for that. But this just kind of gave us a general sense to say, we had this view because we were collecting this information against this population in this one county over that entire period of time. And it raises a lot of questions. And so we're actually beginning some work right now with George Washington University and some data scientists and social psychologists to really try to go into this a little bit deeper and see if we can't answer some of those questions. is there a sensitivity, with this particular population because of COVID? And do we see these trends happening in different places because of it? But I think the ultimate point, to show this to you is to say, this is the information that Palm Beach County has had and is now looking at, and they can take a completely different approach to how they are allocating resources during this very challenging time, how they're marshaling services for various populations during this time, and really having the opportunity to just see things a little bit differently than they couldn't before. Before they were operating blind, and now they've got a little bit more that they're able to see as they go. If you can go to the next slide. So I think this now gets into sort of the operational elements of working with H4 technology. One of the aspects that we know is this is a survey instrument, and surveys are fraught with all kinds of challenges, as we know. Individuals can get fatigued of surveys. There is in some populations too, and having worked in technology for quite a while, especially web technology and mobile technology, we have a lot of apps on our phone, and for some folks, adding another application and logging into that application for something small, it creates a barrier. And so what we wanted to do was, in terms of getting the survey to people where they are, was to put it into basically a mobile-friendly way, so that it goes to places where people already are. They don't need to add any new applications, but they have email. They can go straight into their email. So whether they're on a mobile phone or a tablet, a laptop, or a desktop computer, it's in their email. They can get it anywhere through that mobile technology, or just through a text message. Text messages today, that's that's where a lot of us are communicating on a regular basis. And so getting that link, that secure link that's tied directly back to that individual's record, is putting it right where people are. They're in their phone, they're on their text messages, they're in their email, and all they got to do is click the link, open a browser, any browser, and complete the survey, and they're done. And then in working with their care providers, we now begin that conversation between that information flow from the survey and into their care. Next one, Craig. And so on your phone or even on a web browser, this is what it looks like. A very simple, easy presentation to get through the survey, see where you are, and get it complete. And part of the rationale behind sort of this approach in automating the delivery of the survey through email and text, like I said, is to get it to where people are. We know that almost all of the population, 90%, has smartphones, and that includes populations that are experiencing homelessness or other certain socioeconomic challenges. Smartphones are just almost ubiquitous in terms of our daily device need. And we know that with various text messages, most are read almost immediately. And if acted upon is another question, but they're read. So we know it's getting to where we want it to go. But in particular with various populations where we know there's higher risk, greater need, that Medicaid population, in some of the research that's been done with from Pew Research, is that with Medicaid patients in particularly, this is easy for that population. It's something that they trust, and they're engaging in that information flow through text messaging. And so we're trying to leverage these technologies that already exist to get the most out of a survey instrument to understand these social determinants of people that are already out in the community, trying to build their lives, trying to maintain them, and try to grow them from day to day. Next one, Craig. And I'll pass it back to Craig here in one moment, but just to give you a quick look. The data can be constructed and framed and dashboarded and reported in a lot of different ways, but through this platform, we can view this up in a lot of different ways using the predictive aspects of the platform, or even just, ensuring that, you can have that instant view into counts, into the quantified elements of the scoring from a rather complex survey tool, and to be able to see the population at a glance. Between just greens and reds, you can get a pretty quick sense of where there are some particular challenges. And if you just look at that graph there that's on the left, that's actually data from Palm Beach County. And against that, population set right there, just looking at the community connectedness portion, although they've got very high cultural community, meaning their values is strong and their beliefs are strong, there's some connection challenges inside that particular community. And so we can see that, and we can see that quantified in the data, and that can be presented in a lot of different ways. Next one, Craig.
Yeah, I would just like to add, all the data that's captured is available to the providers and users or administrators of the system. The other nice thing is for one group we're working with, they initially came on board to do data aggregation between their EMR and financial systems. And then we showed them this. And so now they can put the SDOH data next to their EMR data within the tool, within one tool. And so it's opening up new possibilities and insights into what they're able to see and measure and monitor, on a daily, weekly basis. So I think before we jump into the demo, are there any questions, fundamental questions on what we've shared so far? Okay. I know it's a big group, so as always, we can we'll jump into a demo. We'll share David and I's contact information at the end. Feel free to reach out to us if you want to discuss or have your own initiatives or social determinants of health projects or inquiries on what you guys have seen in your communities. So.
Great. Craig, if you'll stop sharing, I'll share my screen. And I'll do, this will be rather brief, but just to kind of give you a sense of really the high level capabilities that are pretty quick to bring into an organization, from concept to launch. When we log in, the system is really framed around, as Craig said earlier, an encounter-based system. So we're talking about encounters, admissions, and discharges. System is very responsive in terms of searching population that happens to be in here. I can search against any status. I can see really anybody that happens to be operating there. If I wanted to just do a big general search and get the entire population, I have that as well. If I've got multiple providers within my particular view, I could choose one of those, and I could do that search, and I could just see that group. Again, just sort of diving into that particular population. Say I know somebody, I want to find me, for instance. I'm just going to go in any active status and search again. So I can take a look at this particular individual. It happens to be me. I can see that survey history. Again, we're focusing primarily on the use of the assessment. So it's seeing these scores and seeing when they were captured. I can go view those rather quickly and take a look at that scoring. Again, this is the survey itself, and those are the responses and the associated scores. So if I'm working with this particular individual, one of the ways that we train and the way that this particular instrument was designed was to be used in conjunction with cognitive behavioral techniques and motivational interviewing. And so we can use these particular scorings to look at individuals thought processes and the way that they have the behaviors and emotions tied to some of the responses that they gave. And then how can we sort of use motivational interviewing to elicit the change process that comes intrinsically from certain individuals. Setting somebody up as a new record is pretty quick and easy. We could do a very quick search. If I wanted to just say that my name was Matt Jones, is he in here? And one of the things that Craig kind of touched on was underneath this is pretty powerful patient mapping indexing, and API connects. So if we're connected into multiple systems and we needed to see across various populations, we'd be able to do this through this search with date of births or social security numbers and get to that right person or consumer that happens to be in here.
Yeah, we can pre-integrate with the EMR, so the data flows over, and you don't have to manually add them. Another thing we are able to do is there's a batch upload functionality, so we can upload records. Maybe at the start of the project, you want to get a census group in to the tool. We can batch upload them, and so that they are instantaneously loaded to the system if you don't have an EMR connection. So,
yeah, and obviously, I'm going through and inputting these, but these could be copied from, another record, another encounter, or as Craig said, they could be connected back from your particular EHR. You choose, again, particular to the Recovery Capital Index, we have these additional, questions that happen to be in here. These responses do not impact the scoring of the instrument. That question comes up often. When the record is created, we then admit the individual, and this then sets off the automation flow. And so here in the test environment, we have simulated 3 months. So we'll now get an email and a text message for today, tomorrow, and the next day. So that simulates the 3 months. General workflow is it's now and then every 30 days for a full year. That goes out. We can see that the survey now has been sent here. And if I click this copy link, I can go directly to the survey. It's going to pop up in my browser. So, if for whatever reason, if we had to actually manually get a verbal question and response, which we tend to not encourage because of various biases, we could input it that way. But I could go over to my text messages, and now you can see, hello, Matt. Here is that same link, and it will open up into a very crowded, tabbed Safari browser over there. Come back. If I go to my own email, now we can see that we have the survey inside my email. I can click there and bring it up as well. I won't go through the 68 questions and respond and get the answer, but the response and the answer calculation is instantaneous. And we can build notifications around those responses as they come back, and against other metrics that you might have. Maybe if it's a percent difference of score over time, we could obviously make that consistent for your team as well. Layered right into the platform is the analytics, and so I don't have to go anywhere else. I'm immediately into the analytics that we've created, and you could do this. You could do these reports in a standard way, which we could provide and build for you, or you can, because this is a self-report, you could build them on your own. And so I'll just bring up, for instance, a new partner that has come along with us. This is something that they're testing to see how they might want to view their data. And again, we can see changes over time from one score to the next. What's that percent change And do we want to do anything about this? And we can see that data across various individuals. If we're interested in just aggregate, obviously we can make that happen. Seeing this information trend over time in the aggregate on a weekly basis. We could break that in groups. Again, there's a lot of different ways to get at this, but then also just seeing at a glance, through color coding, where are there issues and challenges, maybe on the qualified responses. So for instance, around financial stress, we see some financial stress there. These questions are flipped. The responses are flipped, at least in the Recovery Capital Index. So agree doesn't always mean a positive response. Sometimes it's a negative response. And then we can just see variations in that. But also on the scoring too, obviously we have the ability to see this spectrum of color and see where are there particular issues of a group or of a particular individual. So again, a lot of different ways to put that together, to dashboard it up. And one thing I didn't show in here, but again, because this is an encounter-based system and we are building it off of these particular consumers, another element that can be tracked in here that we have built in here are sessions. So, if you wanted to layer the intervention timing against a particular scoring, that can be done as well, because we have the ability to capture those sessions basically as a short assessment or survey, and then we could layer that data together to see, okay, this individual missed a lot of their sessions over the course of the last few months. It resulted in a change in their score downward. That's pretty obvious. That's what we should see. But this could give us some more predictive elements as we bring that data together in a particular instance.
And we're also reporting against services provided. So when we set up a new provider, we can add the services and track and trend the scores over various services to see what measures are being impactful. So.
And the dashboarding is responsive, so you don't need to build a whole bunch of different sort of static dashboards. You can start at a very high level with various filtering. I've now changed one of those filters off of just clicking on that particular pie chart. So we'll get a rather instant refresh. So now we're going to see, all this data. Again, this is a hodgepodge of data just from the test environment. There's not a whole lot of making any sense of this at this particular point, but we now have that responded in a way that we would want. Anything else you want to add, Craig?
Oh, just the instrument is validated and has its standardized sub-scores, and those sub-scores roll up to that social capital, cultural capital, physical capital categories. But we're finding, every provider is a little different in how they want to view the data and maybe what areas or what programs they want to run the RCI on. And so using this tool and being able to be flexible in the reporting is a benefit to the providers and how they want to see and what they want to see. So.
I have nothing additional in terms of a demonstration to share from that. So open to questions. If you want to ask those in the chat, feel free to do so, or you can unmic and ask away.
Oop, we got
I will
percentage response, David.
Yeah, so on the initial, it's pretty high. So for baseline, it's pretty high. It's about 80–90%. As we start to move further down to 60 days, 90 days, 120 days, we sort of start to average out about, depending upon the population. If there's high engagement, percentages 40 to 50%. If there's really low engagement, and if it's used as more of a passive outcomes tracking or a pulse tracking, engagement drops or response drops simply because of engagement structures. But we've been working with organizations to change that. So kind of on average, pretty typical survey response around 25 to 30%, which actually might be a little bit higher than the averages that we might have that are out there. It's a very good question. We do know, and I'll add, sometimes we get asked the question, in particular to this instrument, at 68 questions, is it too long? It can be, and it can be over time. And so we've just completed reliability testing on 2 shorter versions, 36 questions and 10 questions. And so those can be, we'll be layering those in over the coming months so that we can have those shorter versions as well. Craig, do you want to answer what EMRs?
Yeah, so we've done integration for behavioral health EMRs with Credible, NetSmart, and a variety of others. And then on the, I guess, physical health side, there's Cerner, and we have a standardized, there's other groups using our standardized API. And so we're able to integrate those data into the system and then get the results back out. So.
I have another question. I don't know if I'm asking this exactly correct, but obviously you were talking about the responses to the survey and you're collecting information that is quite important. That's obvious. Are you seeing, or do you have any studies that talk about the outcomes that you're deriving based on the fact that you have this information and whether or not you're able to see change in behaviors of people and improve their health?
Yeah, that's a really good question, Kim. And so in terms of studies, I'll just sort of hedge on that word a little bit. The organization that I was previously with, Face It Together, we had an internal evaluation scientist. And so we did regularized ongoing evaluations to answer those exact questions. And because we had the structure of this data as broad as it was, we were able to actually see those types of outcomes at various intervals. So just using addiction, for instance, individuals who might be highly motivated upon that initial entry of that service or treatment, typically their scores were higher, they were elevated. And that's what I would call kind of a hope effect around that. As the intervention started to take place or the care was being delivered and reality was setting in, we'd see scores go down. But over time, and again, across multiple populations, we'd see the score increase again after 90 days, 120 days, and 180 days as individuals start to stabilize and build more growth patterns and change patterns. I hope that kind of answers your question, but I think just generally, yes, we're able to track and measure out those sort of qualitative types of outcomes.
Hey, this is Patty. Hello. I have a couple questions. So does the platform, first of all, does it allow for any ability to increase like medication adherence for patients? That's question one. And then two, is it designed for non-English speaking patients?
Great questions.
I can probably answer the first to the medications. I think that just depends maybe on your adherence model. I suppose, Craig, in various ways, it can be structured to help improve that. On the language, we're currently, at least with the Recovery Capital Index, that's being translated into Spanish right now, and we hope to have that available. And again, the survey itself is front-facing to that patient population, so they would see that in either English or Spanish. The platform itself, Craig, I don't know if you have the platform designed for other languages.
I think they're looking at Spanish translation piece for the module itself, the encounter-based screen. That's not currently live though, but it's on the roadmap.
Okay, thank you.
Any other questions?
Okay.
All yours, Greg.
Yeah. No, I appreciate it. We will send out a recording of the discussion and demo to all the participants online, as well as maybe the slides after we publish it out. Once we appreciate everyone's time today. I know an hour of your day is very valuable. So in closing, I think we just like to say thanks for letting us tell and share our story on how this is affecting providers and the impact it can make, going forward. So if you want any further follow-up information, we'll share our contact information and please reach out to us. So. Okay. Well, I appreciate it. I'm going to put mine, I think my contact information's here. Craig at h4technology.com, 402-598-6561. Our website's got more information. David, you want to give out yours?
Yeah, my email is david@commonlywell.com. And my phone number is 218-779-8546.
Perfect. I appreciate it. Everyone, David, thank you again. Always good to present and share the story with you.
Thank you, Craig. Thank you, everybody.
Thank you.
Thank you, Craig.
Sorry, I got to go to the full screen thing. All right. I'll wrap it up and send you the link to the video.
All right. Thanks a lot.
Thank you.